This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. Copyright 2016, all rights reserved. My name is Shauna Strickland. I am a registered respiratory therapist, asthma educator, and Associate Executive Director at the AARC. I welcome you to today's presentation, Interventions to Optimize Oxygenation During Mechanical Ventilation. Upon completion of this AARC webcast, participants will be able to discuss the balance between oxygenation and lung protection, state the appropriate oxygenation target for mechanically ventilated patients with acute respiratory failure, describe approaches to PEEP titration in patients with ARDS, and discuss the roles of prone positioning in inhaled vasodilators to improve oxygenation. I am pleased to welcome Dr. Dean Hess. Dr. Hess is a registered respiratory therapist and fellow of the AARC. He is the editor-in-chief for respiratory care and just recently retired as the assistant director of the respiratory care at Massachusetts General Hospital and associate professor of anesthesia at Harvard Medical School in Boston, Massachusetts. In addition, Dr. Hess has published many manuscripts and textbooks. Dr. Hess discloses relationships with Daedalus Enterprises, Philips Respironics, Medtronic, Bayer, Jones & Bartlett, McGraw-Hill, UpToDate, and the American Board of Internal Medicine. I disclose that I am a paid employee of the AARC. Brand names of products and or medications may be mentioned only as examples of technology. Any use of brand names is not in any way meant to be an endorsement of a specific product, but to merely illustrate a point of emphasis and to provide information and education regarding the availability. Dr. Hess, welcome to the program.
Thank you very much, Shauna. It's certainly my pleasure to be here today and talk about something that we all need to deal with in the ICU when caring for mechanically ventilated patients, which is providing adequate oxygenation. But there has been, certainly over the last 20 years, a paradigm shift where certainly early in my career, we focused primarily on providing an adequate arterial PO2 or oxygen saturation for our mechanically ventilated patients. But we now know that lung protection is equally, if not even more important than providing a high PO2 or oxygen saturation. So what we need to do then in our practice is to balance oxygenation against lung protection. And when we think about oxygenation, we need to think not only about our patient's arterial PO2 and oxygen saturation, but we also need to think about oxygen delivery, which includes cardiac output. So if we use maneuvers that improve the arterial PO2 and the oxygen saturation, but it reduces the cardiac output and reduces oxygen delivery to tissues, that's really not of much benefit to our patients. And then as far as lung protection, I hope that we all agree now that we should target a tidal volume of about 6 mLs per kilogram of ideal body weight in our patients, and I would say in our patients not only who have ARDS, but also in mechanically ventilated patients who do not have ARDS. We want to target a plateau pressure of less than 30 centimeters of water, and we want to provide an appropriate level of PEEP for our patients, and we'll talk a lot about setting PEEP in this presentation. So who of us doesn't want to end our shift with our patient having a high arterial oxygen saturation or pulse oximetry, oxygen saturation? Who doesn't want to see the oximeter reading out 100% oxygen saturation? But one of the points that I want to make right at the outset today is we need to beware of the seduction of the pulse oximeter, because there are things that we may do that would drive up the oxygen saturation and result in our patients having a higher SpO2 and a higher arterial PO2 that might be injurious to our patients in the long run. And we know, for example, just from the ARDSNet study, the patients who were targeted to have a lower tidal volume had better outcomes as far as survival, but their blood gases were not as good. So we don't have to look any further than the ARDSNet study to see an example of where lung protection with poorer blood gases resulted in better outcomes. So that then brings us to our first poll question, and I'll ask for Emily's help here pulling up the poll question, which is, what do you think is a reasonable oxygen saturation target? 88 to 95%, 92 to 95%, greater than 95%, or 100%. So what would you call a reasonable oxygen saturation target?
Excellent, Dean. And the potential answers for our polling question here are 88 to 95%, 92 to 95%, greater than 95%, or 100%. So for our attendees, you'll want to go ahead and click the radio button next to the answer the best specifies the best answer for you. So go ahead and do so. And as we do have our answers finalizing here, Dean, it does look like about 55% of our audience is saying, between 88 and 95%. We have about 39% saying between 92 and 95%, 6% saying greater than 95%, and about 1% saying 100%.
Well, I would agree with those of you who chose 88 to 95%. So it appears to me that you must have somewhere along the line read the ARDSNet study. So this is the ARDSNet study published now more than 16 years ago in the New England Journal of Medicine, comparing lower tidal volumes with higher tidal volumes, or 6 mLs per kilogram against 12 mLs per kilogram. And in both groups, both the group that was targeted for 6 mLs per kilogram and the group targeted for 12 mLs per kilogram had an oxygenation goal of a PO2 of 55 to 80 millimeters of mercury, or an oxygen saturation of 88 to 95%. So I think a reasonable target oxygenation would be a saturation of about 88 to 95%, and we can use the ARDSNet study as support for that targeted range of oxygenation. I also think it's important to point out that only about 10% of patients with ARDS who die, or only about 10% of ARDS mortality, results from refractory hypoxemia. So the reason why patients with ARDS die is usually not because we have trouble oxygenating them. And I would submit to you that it's more likely that patients with ARDS die because we provide lung mechanical ventilation strategies that are not lung protective, rather than because we have difficulty oxygenating the patient. Now, this is, I think, an interesting study that was published a few years ago now in Respiratory Care, looking at the practice of excessive FiO2 and the effect on pulmonary outcomes in mechanically ventilated patients with acute lung injury. And here the authors defined excessive FiO2 as greater than 0.5, despite the oxygen saturation being greater than 92%. And they found that although there was no difference in mortality when there was excessive FiO2 versus no excessive FiO2, they did find that at 48 hours, the oxygenation index was worse in patients receiving excessive FiO2. Those receiving an excessive FiO2 spent more time on the ventilator, more time in the ICU, and more time in the hospital. So we have some evidence then that suggests that if, as respiratory therapists, we do not carefully titrate the FiO2 and we expose our patients to more oxygen than they necessarily need, that can result in poorer outcomes. And in fact, the authors of this study suggested that optimal titration needs close monitoring and may be a potential area for greater participation of respiratory therapists, which is a point that I agree with. So one of the things that we as respiratory therapists should be doing in the ICU, caring for our mechanically ventilated patients, is titrating the FiO2 to a reasonable oxygen saturation. And again, I think a reasonable target oxygen saturation is 88 to 95%. Now, one of the things that we may think about in a patient who are having difficulty oxygenating is whether or not we may perform a recruitment maneuver. So what is a recruitment maneuver? Well, this is an increase in airway pressure with the goal of opening collapsed lung tissue or opening collapsed alveoli. A popular recruitment maneuver has been to provide a breath hold or a CPAP pressure of 40 centimeters of water for 40 seconds. And this is the type of recruitment maneuver that was probably most commonly described in the literature for many years. However, now I think the stepwise approaches are what we should be encouraging. And in fact, Marini, in an editorial a few years ago, suggested that stepwise approaches are more effective than abrupt applications of high pressure, and the graded rise in pressure is better tolerated. So what might this look like? Well, here is an example of a stepwise recruitment maneuver. Also, this is an incremental PEEP titration initially, with then a decremental PEEP. These are actually data from a real patient who I took care of a couple of years ago, who has severe ARDS, gets intubated, is placed on a tidal volume of 6 mLs per kilogram on 100% oxygen and 10 of PEEP. The oxygen saturation is 79%. And then you can see that in about 3 to 5 minute intervals, we stepped up the PEEP from 10 to 15 to 20 to 25 centimeters of water. When we got up to a PEEP of 25 centimeters of water, there was an abrupt increase in oxygen saturation to 96%. However, notice now that the plateau pressure is greater than 35 centimeters of water. So we have effectively opened the lung at a PEEP of 25 centimeters of water, but may be potentially injuring the lungs due to the high plateau pressure. So then we step back the PEEP from 25 to 20 centimeters of water, also reduced the tidal volume to less than 6 mLs per kilogram. That maintained the level of oxygenation, but now the plateau pressure is at a more acceptable level. So this might be an example of a stepwise PEEP titration, where there is an incremental levels of PEEP that are applied, and then when we overshoot as far as lung protection, then we back off on the level of PEEP. Now, what is the evidence to support the use of recruitment maneuvers? Well, this is a meta-analysis published a couple of years ago, and the results of this meta-analysis suggest that there is some evidence to support a lower hospital mortality with the use of recruitment maneuvers. However, the authors also point out that the quality of the current evidence is low and insufficient in terms of allowing for definitive and reliable conclusions, and thus further research is likely to impact our confidence in the estimate of the effect and may change the estimate. So in other words, although there is some evidence to support that the use of recruitment maneuvers might not only improve oxygenation, but may result in some mortality benefit, that evidence is currently not robust. And I think I would say today that if you use recruitment maneuvers in your practice, that I cannot say is not correct. However, if you do not use recruitment maneuvers in your practice, I cannot I can also not say that is not correct. So I think there's still some equipoise around the use of recruitment maneuvers. Now, what about the use of higher versus lower levels of PEEP? So in patients with ARDS who were ventilating at a tidal volume of 6 mLs per kilogram of predicted body weight or ideal body weight, is there any difference in outcomes if we use a higher level of PEEP versus using a lower level of PEEP? And this has actually been investigated now over the last almost 15 years in 3 randomized controlled trials. First of all, the alveoli study from the ARGNET group, looking at higher versus lower levels of PEEP in the United States. The LOVE study that was conducted in Canada, again, looking at higher versus lower levels of PEEP. And then the EXPRESS study, which was done in France, again, looking at higher versus lower levels of PEEP. And the bottom line is, from each of these 3 randomized controlled trials, there was no difference in outcomes for higher versus lower levels of PEEP. In other words, higher levels of PEEP, although they may have resulted in better oxygenation, these 3 randomized controlled trials failed to show that resulted in better patient outcomes, better survival specifically. So then why is that, I wonder? So why is it that these 3 randomized controlled trials were unable to show an improvement in outcome with higher levels of PEEP in patients with ARDS? Well, here's one reason, or there's one way that I think we might explain those results. So imagine you have a patient who's being ventilated at a PEEP of 10 centimeters of water and a tidal volume of 6 mLs per kilogram, and the plateau pressures are in the low 20s. And then we increase the PEEP from 10 to 15 centimeters of water. And when we do that, there is a large increase in the plateau pressure. So notice that in this example, we increase the PEEP by 5, but the plateau pressure goes up by a lot more than 5. In other words, the compliance decreases. And in fact, now we are subjecting our patient to a potentially harmful plateau pressure. So in this case, the injury due to overdistension and the high plateau pressure may outweigh any benefit due to the additional alveolar recruitment associated with a PEEP of 15 rather than 10 centimeters of water. But now let's look at another potential patient. And in this hypothetical patient, we increase the PEEP from 10 to 15 centimeters of water. Again, the tidal volume is 6 mLs per kilogram. And in this patient, the plateau pressure perhaps only increases by 1 or 2 centimeters of water. In other words, the increase in plateau pressure is less than the increase in PEEP. And in fact, the plateau pressure here is at a level that most of us would consider safe. So here the increase in PEEP results in more alveolar recruitment, a higher compliance, and here the benefit of the additional level of PEEP may outweigh the potential for injury due to the plateau pressure going up by only a few centimeters of water. So now imagine that we do a randomized controlled trial of 1,000 patients with ARDS, and half of our patients respond to an increase in PEEP with potentially injuring their lungs, whereas the other half of the patients respond to an increase in PEEP by beneficial effects within the lungs. I think it's easy to see how we may have a negative study. In other words, using higher versus lower levels of PEEP may injure some patients' lungs, may benefit other patients' lungs, and when you put it all together, it results in a negative study. I think it's also possible, in fact, I think it's quite likely, that the response to PEEP may depend upon the severity of the ARDS. So here is an individual patient meta-analysis of those 3 negative randomized controlled trials that I showed you a few minutes ago. And in this meta-analysis, they divided patients into those who had moderate to severe ARDS, in other words, a PO2 to FiO2 ratio of less than 200, versus patients with mild ARDS, those who had a PO2 to FiO2 ratio of 200 to 300. And you can see that in the patients with moderate to severe ARDS, PF ratio less than 200, there is benefit in terms of survival with the use of higher levels of PEEP. The probability of survival is greater with higher. Whereas in patients with mild ARDS, those with a P to F ratio greater than 200, there was harm with the higher levels of PEEP. And as you can see on the right-hand side of the panel, the patients who had received lower levels of PEEP were more likely to survive if they had mild ARDS. So this then suggests to me a couple of things. First of all, about that, everyone. Somehow I got dropped out of this call, but I think I'm back in and we're going to continue. So we were talking about maybe if we just back up quickly to recap, we were talking about how there were 3 randomized controlled trials looking at higher versus lower levels of PEEP for ARDS, and those 3 trials were all negative studies as far as patient survival. And then we said that one reason why those studies might have been negative is if we increase PEEP, in some patients there may be harm due to overdistension, whereas other patients there may be benefit in terms of alveolar recruitment. But then if we do a study where half of the patients fall into each of these groups, we may end up with a negative study. And then I had pointed out that there was an individual patient meta-analysis of these 3 negative randomized controlled trials where they divided patients into those who had moderate to severe ARDS, in other words, a PO2 to FiO2 ratio of less than 200, versus those who had mild ARDS, with a PO2. Okay, well, again, I apologize because the call got dropped, but we will continue here with this slide, which is showing us that there was better survival in patients who had moderate to severe ARDS with the use of higher levels of PEEP, versus there was better survival in patients with mild ARDS if they received lower levels of PEEP. So this, I think, tells me 2 things. First of all, we should use higher levels of PEEP for moderate to severe ARDS, lower levels of PEEP for mild ARDS. And also it tells us that in patients with moderate to severe ARDS, there is a greater potential for recruitment than patients with mild ARDS. So then the question that we might ask is, well, how do we go about setting PEEP in our patient, particularly a patient with ARDS? And there have been a number of different approaches that have been described in the literature over the years. So we can set PEEP based upon gas exchange, and we'll talk a little bit about that in a minute. We can set PEEP based upon respiratory mechanics, and we'll talk about that in a minute. We can set PEEP based upon imaging, which is an area which I think is exciting, but we won't talk about that today. And we can either set PEEP with an incremental PEEP titration or a decremental PEEP titration, and we can even combine that together into one maneuver, as I showed you before, where we used an incremental PEEP titration as a recruitment maneuver and then stepped back on the level of PEEP when we overshot as far as plateau pressure. Now, the technique that has been used to set PEEP in the ARSNet studies has been the use of a PEEP FiO2 table, as you can see on this slide. And in the ARSNet studies, there have been two PEEP FiO2 tables used, particularly in that study that compared higher versus lower levels of PEEP. And essentially what one does here is to choose a combination of FiO2 and PEEP to maintain the oxygen saturation in the target range of 88 to 95%. Now, what we might consider doing is using the PEEP FiO2 table that targets lower levels of PEEP for patients with mild ARDS. So that's the upper table on this slide. And we may use the PEEP FiO2 table that targets higher levels of PEEP in patients with moderate to severe to ARDS. So one approach that we might use to titrate PEEP is to use the PEEP FiO2 tables as were used in the ARSNet study, and using the one that targets lower levels of PEEP for mild ARDS, the one that targets higher levels of PEEP for moderate to severe ARDS. And I think one of the big advantages of this approach is that it can be implemented easily in any ICU in the care of any patient on a ventilator without any additional equipment whatsoever. So this is an incredibly practical, easy way to set PEEP and FiO2 in a mechanically ventilated patient. Now, another approach that we might use to setting PEEP is to set PEEP according to best compliance. And this is actually first described way back in 1975 by Peter Suter and his group, where they showed that the highest compliance, shown by the vertical line in the figure, the highest compliance was associated with the best oxygen transport or the best oxygen delivery to tissues. So this is, again, I think, a technique that can be easily implemented in any ICU. All of us as respiratory therapists know how to measure and calculate compliance in our patient by simply taking the tidal volume divided by the difference between plateau pressure and PEEP, and titrating the PEEP according to the highest compliance. So the idea is here that if we overshoot in our level of PEEP, then the overdistension that results will result in a decrease in compliance. Or if we undershoot in our level of PEEP, there will be more alveolar collapse, and that will result in a decrease in compliance. So in other words, the idea here is to choose the level of PEEP that is associated with the best compliance. I would point out that in one of those randomized controlled trials that I showed you earlier, the French study, they titrated PEEP to the highest level of PEEP that they could use to keep the plateau pressure between 28 and 30 centimeters of water. And that's just another way of titrating PEEP according to tidal compliance. The denominator in the compliance equation, plateau pressure minus PEEP, is what is now referred to as driving pressure. And so one way of thinking about titrating PEEP is to titrate PEEP to the lowest driving pressure, the lowest difference between plateau pressure and PEEP, which will correspond to the highest compliance if the tidal volume is kept constant. So why the interest in driving pressure? Well, this paper, published now a little bit over a year ago in New England Journal of Medicine, was a secondary analysis of a lot of studies, a lot of mechanical ventilation ARDS studies. And what they did in this study was to look at the relationship between mortality and driving pressure. Again, driving pressure being the difference between plateau pressure and PEEP. And as you can see in this figure, the risk of mortality, the risk of hospital mortality, was less than 1 if the driving pressure was less than 15 centimeters of water. So something then that I think we should pay attention to when ventilating all patients, but in particularly ventilating patients with ARDS, is the driving pressure, the difference between plateau pressure and PEEP. And we should be targeting that to be less than 15 centimeters of water. So something to keep in mind as we titrate PEEP. Now, another approach to titrating PEEP that has been described for many years, probably more than 25 or more years, is by looking at the pressure volume curve in a mechanically ventilated patient. And in patients with ARDS, the pressure volume curve typically has a sigmoidal relationship with a lower inflection point as shown on the slide and an upper inflection point also shown on the slide. And the lower inflection point has been thought to be the level at which the level of PEEP at which there is a large population of alveoli that are recruited. And the upper inflection point is thought to be the level at which there is alveolar overdistension. So then we might want to keep the plateau pressure lower than the upper inflection point and keep the PEEP greater than the lower inflection point to ventilate the patient on the steepest part of the pressure volume curve. And in fact, 15 years ago or so, this was something that I was quite enthusiastic about. And in fact, we did several studies that I was part of looking at pressure volume curves in patients with ARDS. However, there are some issues with the pressure volume curve that we need to keep in mind. Some of them I've listed on this slide. And I can tell you that I am less enthusiastic about using pressure volume curves to set PEEP today than I was, say, 15 or 20 years ago. But again, the idea of using the pressure volume curve is to set the PEEP greater than the lower inflection point on the PV curve. I think it's also important to appreciate that the pressure volume curve, or the shape of the pressure volume curve, will be determined to some extent by the manner in which we measure it. So the traditional way of measuring the pressure volume curve, and the technique that I was using back in the 1990s in my own practice, was to take a calibrated syringe, attach it to the endotracheal tube or tracheostomy tube of the patient, and then make step increases in volume, measure the pressure with each step increase in volume, and then plot out the pressure volume curve, as you can see on this slide, and then determine where the upper and lower inflection points are and set the ventilator accordingly. So the traditional way of measuring the pressure volume curve was a static maneuver with step changes in volume from a calibrated syringe. Now, today, virtually all of the ventilators that we use have the ability to display a pressure volume curve. But I would suggest that we need to be quite careful about that, because the shape of the pressure volume curve displayed on the ventilator screen will be determined to a large extent by how we set the ventilator. So in this example, in the lower panel, you can see that the pressure volume curve looks quite different when we set the ventilator for pressure control versus volume controlled ventilation when there's nothing else that changes in the system. And in fact, in pressure control, in this example, we would believe that there is a lower inflection point, where in reality there is not one if we use volume controlled ventilation with a constant inspiratory flow. So be careful about the dynamic pressure volume curve that you can see on the ventilator screen and using that to set the level of PEEP. Now, there are some ventilators that will do a slow flow inflation of the lungs to determine the pressure volume curve, and that is probably a reasonable way to get to display a near true PV curve as we may get with the calibration syringe. So if you use a ventilator that's capable of doing a slow inflation maneuver to determine the pressure volume curve. That might be a reasonable way of determining the PV curve. But again, in my own practice, haven't used a pressure volume curve to set PEEP in a number of years. Now, a technique that's been described just within the last 10 years in the literature, and one that I am enthusiastic about, is the use of a stress index. And how this works is that we set our ventilator for a constant flow, volume control form of ventilation. So this requires volume control with constant flow. We cannot do this with pressure control. We cannot do this with volume control and a descending ramp of flow. So we set the ventilator for a constant inspiratory flow, and then we look at the shape of the airway pressure time graphic. And if we see that as we inflate the lungs with a constant flow, there is a linear increase in pressure over most of the breath, as is illustrated here, that is a stress index of 1, and in fact, that's the sweet spot. So what we should see is as we inflate the lungs with a constant flow, there's a relatively constant increase in pressure over most of the breath. And we discard the first part of the breath because that's affected a lot by the resistance through the endotracheal tube. Now, if we look at the airway pressure waveform, and we see that there is downward concavity, which is a stress index of less than 1, that suggests that there's tidal recruitment. So in other words, as the pressure in the lungs is increasing, alveoli are popping open, the breath is going into a larger space, and the compliance is getting better. The problem with tidal recruitment is then during exhalation, there is tidal derecruitment. So then if we see a downward concavity in the airway pressure waveform, that suggests that we should use a higher level of PEEP. So we should use more PEEP so that we can get rid of that downward concavity and resolve and get an increase in pressure that is more constant or stress index of 1. On the other hand, if we look at the shape of the airway pressure waveform and there is that suggests overdistension. In other words, we are reaching the elastic limits of the lungs and the chest wall, and that results in the compliance getting worse, requiring higher levels of pressure near the end of inspiration. So that's a stress index of greater than 1, and that would suggest that we should either lower the PEEP or lower the tidal volume or both. Again, the sweet spot is a stress index of 1, where the rise in pressure is relatively constant over the inflation of the lungs with the tidal volume. So let me show you some examples. So here's a patient with severe ARDS who gets intubated a few years ago, and on a PEEP of 8 centimeters of water, there's downward concavity of the airway pressure waveform. We used some curve fitting software, and we found that the stress index was 0.75. So that would suggest that we should increase the PEEP. So we then increased the PEEP from 8 all the way up to 18 centimeters of water, and I think you can appreciate that now the rise in pressure is more constant over inflation, and when we did our curve fitting, the stress index now is close to 1, or is 0.97. Now in the lower panel is another patient. So this is a patient who got transferred to our ICU after more than a month of ARDS. There's a lot of scarring in the lungs, probably less potential for recruitment late in the phase of ARDS. The patient is on a PEEP of 10 centimeters of water. You can see by eye the upward concavity of the airway pressure waveform, and the stress index we calculated at well over 1.38. And in this patient, we actually had to reduce the PEEP all the way down to 0 to bring the stress index closer to a stress index of 1. So here's an example of a patient who by stress index has potential for recruitment, and we increased the PEEP on the top, where another patient on the bottom has a stress index greater than 1, likely alveolar overdistension, and we reduce the PEEP in order to reduce the stress index. And I would submit to you that you can identify this without doing any mathematical curve fitting by simply eyeballing the pressure time graphics on the ventilator screen. So here are just some pictures that I took with my iPhone. On the bottom is a PEEP of 12, and then on the top we increased the PEEP to 15 centimeters of water. And I think you can see with the increase in PEEP from 12 to 15 centimeters of water, there is now some upward concavity on the airway pressure waveform. If I apply a straight edge or straight line, that even becomes more obvious. So in this patient, we managed the patient on a PEEP of 12 rather than on a PEEP of 15, because on the PEEP of 15, there is evidence of alveolar overdistension. Now, something that's been known for a number of years, and this was described by Gatnoni way back almost 20 years ago, is that in some patients with ARDS, the lungs are characterized primarily by consolidation, whereas in other patients with ARDS, the lungs are characterized primarily by atelectasis. And sometimes this is called direct versus indirect ARDS, or pulmonary versus extrapulmonary ARDS. And in the patients whose lungs are primarily consolidated, if we increase the PEEP, we get a shift of the volume pressure relationship where the compliance gets worse. So in patients with primary consolidation, where there's less potential for recruitment, if we increase the PEEP, we get overdistension and the compliance gets worse. Whereas in patients with ARDS, where the problem is primarily atelectasis, if we increase the PEEP, now we get alveolar recruitment. And one of the things that Gatnoni pointed out in this study from back in 1998 is the patients whose ARDS was characterized primarily by atelectasis had a decrease in chest wall compliance. So the suggestion was that in patients with ARDS with a lot of atelectasis, maybe it is the stiff chest wall which is pushing in on the lungs, causing alveolar collapse, and then we need to use enough PEEP to counterbalance the effect of the chest wall in order to maintain alveolar recruitment. So here is an example of that. So here's a patient transferred to us, 49-year-old male, acute pancreatitis, comes from an outside hospital for ECMO due to hypoxemic respiratory failure. He has a firm abdomen. His bladder pressure was measured at 21 millimeters of mercury. If you do the math, multiply times 21 times 1.36, you get 28 centimeters of water. So the PEEP was increased to 28 centimeters of water. And then we put in an esophageal balloon catheter. And what you're looking at here is airway pressure in the top graphic, esophageal pressure in the center graphic, and then the difference between the two, airway pressure minus esophageal pressure, or transpulmonary pressure, in the graphic on the bottom. And by measuring esophageal pressure, we get an index of pleural pressure. So we use esophageal pressure as a proxy for pleural pressure, which tells us how much the chest wall is pushing in on the lungs, producing alveolar collapse. And in fact, in this patient, when the PEEP was 28, the esophageal pressure was 25, so the end expiratory transpulmonary pressure was 3 centimeters of water, or in other words, the PEEP was just a bit higher than the pleural pressure, suggesting that the PEEP is counterbalancing the collapsing effect of the chest wall. Now, some of you are probably wondering, well, if the PEEP is 28, what is the plateau pressure, and is that injuring the lungs? Well, here is the plateau pressure in that exact same patient, which is 40 centimeters of water. However, when the plateau pressure is 40 centimeters of water, the esophageal pressure is 30 centimeters of water. So the true end inspiratory distending pressure on the alveolus is only 10 centimeters of water. So in other words, the pressure in the alveolus at the end of inspiration is only 10 centimeters of water greater than the pressure in the pleural space, which we're measuring with an esophageal balloon. So in this case, because of the chest wall effects, I would argue that this plateau pressure of 40 centimeters of water might actually be safe, and it may be necessary so we can provide enough PEEP to counterbalance the collapsing effect of the chest wall. So then you may ask, well, which is better, if we use the PEEP FiO2 tables like the ARSNet used, or if we titrate PEEP according to best compliance or stress index or esophageal pressure. And this is an interesting study published about 2 years ago now, again by Gatnoni's group, where they showed that if you look at the level of PEEP corresponding to the potential for lung recruitment. So what we're looking at on the x-axis is the potential for lung recruitment, and you would argue that in patients with a greater potential for lung recruitment, we should use higher levels of PEEP. And the only approach that accomplishes that is the table, such as the table that was used by the ARSNet group. So this would suggest then that we should, that it's perhaps reasonable to consider using a PEEP FiO2 table like the ARSNet study in order to set PEEP. And as I said earlier in the presentation, that is certainly a very practical way of setting PEEP at the bedside. Now, it was also nicely shown in this study that when we increase the PEEP, say by 5 centimeters of water, there are some patients in whom the PO2 goes up, but there are also some patients in whom the PO2 goes down, interestingly enough. And there are some patients where if we decrease the PEEP by 5, their PO2 goes down, but there are also some patients in whom if we reduce the PEEP, their PO2 goes up, or the PO2 FiO2 ratio goes up. And then there are some patients where if we don't do anything, we just keep the PEEP where it is and watch the patient over time. In some of those patients, the PO2 goes down, and in some of those patients, the PO2 goes up. So why is this important? Well, in this same study, they showed that if we increase PEEP and the PO2 goes down, so if there's an increase in PEEP and the PO2 goes down, that results in a higher mortality, a higher probability of death. Because likely, if we increase the PEEP and the PO2 goes down, that means that the patient's lungs are not very recruitable, so we produce alveolar overdistension, and that alveolar overdistension not only results in a drop in PO2, but also results in lung injury. So I would say be very careful if you turn up the PEEP and the oxygenation gets worse, because this study would suggest that carries with it a poorer outcome for the patient. So then how do we select the right level of PEEP? Well, I think a very provocative paper, a review published now about 1.5 years ago, suggests that the best PEEP maybe does not exist. And maybe the term we should be using is better PEEP, as a reasonable compromise between oxygenation, hemodynamics, and tidal opening and closing of alveoli. And in fact, these authors, Gatnoni et al., suggested that we should use 15 to 20 centimeters of water of PEEP in severe ARDS, 10 to 15 centimeters of water in moderate ARDS, and 5 to 10 centimeters of water in mild ARDS. So in other words, we should be thinking about a level of PEEP relative to the severity of the lung injury. So now let's turn our discussion away from PEEP titration. So most of my presentation had to do with PEEP titration, because that's something that certainly all of us can do every day in our ICUs when caring for patients with ARDS. And perhaps another thing that all of us could do in our ICUs, if indicated, is to use prone positioning in order to improve oxygenation. And one of the points that I want to make is that prone positioning has been described for many years. In fact, here's a paper published way back in 1977 suggesting that we might think about prone positioning as a way of improving oxygenation in mechanically ventilated patients with ARDS. So prone positioning has been described, has been around for really a long time. And I think everybody appreciates that prone positioning can improve oxygenation in probably the majority of patients with ARDS. This meta-analysis nicely shows an improvement in oxygenation with prone positioning. But perhaps a more important question might be whether that improvement in oxygenation is associated with a survival benefit. And this got a lot of attention with this paper by Guerin published in the New England Journal of Medicine now about 3 years ago, where they looked at prone positioning in patients with severe ARDS and showed that with prone positioning, not only was there an improvement in oxygenation, but the patients who were randomized to prone versus supine had a greater probability of survival. So the prone positioning for severe ARDS then may have a survival benefit in addition to being a way that we can improve the patient's oxygenation. Now, if we drill down in this study a little bit further, we can see that when patients were randomized to either supine or prone positioning, the levels of PEEP that were used were really quite modest. PEEP on average of about 10 centimeters of water. And I might argue, and others might agree with this, that in patients with severe ARDS, PEEP of 10 centimeters of water might not be enough. And in fact, I have to wonder that if they would have increased the PEEP to 15 or 18 or 20 centimeters of water, how many of these patients would have still qualified for enrollment in the study because of severe ARDS. And then you can also see that on average, the PO2 to FiO2 ratio in the two groups was about 100 millimeters of mercury. So in other words, they used prone positioning versus supine positioning in patients with, or they randomized patients to prone versus supine positioning who had severe ARDS, who were being ventilated on modest at best levels of PEEP. But they did, for sure, show that there was a survival benefit. And in this meta-analysis that was done after publication of the Guerin study, it was shown that if you look at studies that were performed over the last 15 years of prone versus supine, certainly now with the inclusion of the Guerin study, there is a signal suggesting that prone positioning, particularly for patients with severe ARDS, may provide a survival benefit in addition to an improvement in oxygenation. Now, one of the things that I think is important for us as respiratory therapists to appreciate is that there are complications associated with prone positioning, and perhaps the more common or the most common complication of prone positioning is facial skin breakdown. These are some nasty looking pictures from a letter we published in Respiratory Care about a year ago now, showing pressure ulcers that can develop on the face of patients while in prone positioning. So something that as respiratory therapists we need to pay attention to when we use prone in our practice. Now, the final thing I wanted to touch on was selective pulmonary vasodilators to improve oxygenation. So the idea is that if we administer a selective pulmonary vasodilator like inhaled nitric oxide or prostacyclin or even oxygen as far as that's concerned, that inhaled selective pulmonary vasodilator will go preferentially to the ventilated parts of the lung. That will improve blood flow to the ventilated part of the lung because of the vasodilation properties. So that will improve ventilation perfusion matching, reduce shunt, will improve arterial PO2, and also by administering the vasodilator by inhalation, the effect is primarily in the lungs with minimal or with very minimal systemic side effects. So the prototype inhaled pulmonary vasodilator is certainly inhaled nitric oxide, and I don't think that there's any debate that inhaled nitric oxide can improve oxygenation, as was shown in this meta-analysis published a few years ago. But the more important question might be whether it improves mortality. And unfortunately, to date, it has not been shown that inhaled nitric oxide affords a survival benefit for patients. And in fact, in this same meta-analysis that showed improved oxygenation with the use of inhaled nitric oxide, they showed no benefit on survival, and if anything, the hint of better survival for patients who did not receive inhaled nitric oxide. And moreover, inhaled nitric oxide can be associated with adverse effects such as nitrogen dioxide production and methemoglobinemia, and a rebound effect when we wean the nitric oxide off. However, as was pointed out in this meta-analysis, there may be the potential for increased risk of renal failure in patients with inhaled nitric oxide. So inhaled nitric oxide then might improve oxygenation, has not been shown to improve survival, and may be associated with adverse effects. There was a more recent meta-analysis of nitric oxide published just a couple of years ago, where again they showed that even when they divided patients into those with severe ARDS versus less severe ARDS, there was not a suggestion, or there was not evidence for an improvement in survival with the use of inhaled nitric oxide. Now, something that has received a lot of enthusiasm over the last couple of years is the use of inhaled prostaglandins as a selective pulmonary vasodilator in patients with ARDS. And as was shown in this meta-analysis, the use of inhaled prostacyclins can result in a significant improvement in oxygenation. So we can get the improvement in oxygenation with inhaled aerosolized prostacyclins like Flolan or Velitri as we might get with inhaled nitric oxide. And the reason I think these have become more popular in recent years is they are much less expensive as compared to inhaled nitric oxide. Here's just from a review that Mark Siebel and I did a couple of years ago, we showed in this review that the effect on PO2 is similar for an inhaled prostacyclin as it is with inhaled nitric oxide. And again, I think the popularity of inhaled prostacyclins in recent years relates to the fact that they're a lot cheaper than inhaled nitric oxide. But something that is important for us as respiratory therapists is that if we are delivering aerosolized pulmonary vasodilators like inhaled prostacyclins, we need to be very vigilant as far as nebulizer performance, checking the syringe pump on a regular basis since these are delivered continuously, making sure that we have filters in the system to protect the exhalation valves of our ventilators and so forth. So something that is very important from a safety standpoint is that if we're delivering aerosolized pulmonary vasodilators, that we have a high level of vigilance to these sorts of things. So I have one more poll question. So Emily, again, if you could help here. So the question that I have now is whether do you believe or do interventions to optimize oxygenation improve outcomes? Do you think they do? Do you think they don't? Or are you unsure?
And once again, for our attendees, just go ahead and select that radio button next to the answer that best fits your ideal. So as our answers are coming in, it looks like about 73% of our audience is saying yes, 12% is saying no, and about 15% is saying not sure.
And I'm pleased to see that many of you are sticking around despite the fact that we had that glitch there in the middle. So it looks like many of you think that interventions to optimize oxygenation improve outcomes. I think I probably have more equipoise myself, and I would probably say I'm still not quite sure. And I think we still have to be careful that with some of these techniques that the benefit outweighs the potential for harm. Well, this was evaluated in a paper we published in Respiratory Care a few months ago. This was a comparative effectiveness study of rescue strategies in 1,000 subjects with severe hypoxemic respiratory failure. And here the authors concluded that rescue strategies continue to be used in a minority of subjects with severe hypoxemia. And in general, there is no benefit to survival seen. So these authors are suggesting that at least in this study, there was no benefit to survival. However, there are a few studies out now that have used individual rescue strategies that are showing improved mortality in selected subjects of patients. So an example of that might be the use of prone positioning in patients with severe ARDS, where a survival benefit has been shown. And then the authors say, the authors, believe further research towards an algorithmic and pathophysiology-based approach for the selection of rescue strategies in patients with severe hypoxemia is warranted. And I would agree with that. And in fact, on this slide is an algorithm that I would suggest that you might consider. Now, I would point out that this is my algorithm. It has not been subjected to any analysis like a randomized controlled trial. So maybe it's the lowest level of evidence. It's particularly since it came from me, it's pretty low level of evidence. But what I would suggest as an approach is that you first make sure that you're using lung protective ventilation. And then you do an appropriate PEEP titration, which may or may not include a recruitment maneuver, depending upon how you feel about recruitment maneuvers. Now, once you get your patient on an appropriate level of PEEP and an appropriate tidal volume, if the patient remains hypoxemic, I would say an oxygen saturation less than 88%, then you consider the use of prone. If there's no contraindication, you go ahead and you put the patient in prone position. If there's some contraindication to prone, then you consider an inhaled pulmonary vasodilator. And one of the things that I see now that I probably should have added to this algorithm is if the patient remains hypoxemic when you go to prone positioning, then you might consider adding an inhaled pulmonary vasodilator with prone positioning. And then in patients who you cannot provide an adequate level of oxygenation, despite prone, despite inhaled pulmonary vasodilators, then you might consider ECMO, something that we're not discussing in this presentation. And certainly we also need to think about things like aggressive treatment of infection, appropriate fluid management, addressing all correctable conditions that we can, perhaps paralysis, something beyond this afternoon's discussion. And also you might consider non-conventional ventilator modes. That is something that is very controversial and not something that we discussed at all in this presentation today. But first and foremost, I think it is important to first do no harm. So one of the things that I hope that I pointed out throughout this presentation is that if we are not careful, we can implement strategies that may result in an improvement in oxygenation, but might also result in the potential for harm so that the long-term outcome of the patient is not improved. So with that, I will stop. I thank you for your attention. I'm sorry about the break in the middle of the presentation while I had problems with my phone. But thanks for those of you who stuck it out here to the very end, and I'll turn this back to Shauna.
Thank you, Dean, and thanks to everyone who is hanging out with us. In the interest of time, what I'll do is compile the questions for Dean and send them to him via email so that he can give us a response. And so when we post the archived presentation, we will also post the transcript of his response to those questions. But, Dean, I do want to ask one question because I think that it kind of encompasses the overall intent of the presentation, and I will publish this into the Q&A tab so that everyone can read it as well. The number of participants in each of the cited studies, is that adequate enough to generalize to the general population of patients with ALI and ARDS?
So I guess it varies. So some of these studies were really quite large. So in the low versus higher PEEP studies, I believe that in some there were more than 2,000 patients who were enrolled. So I think each of those, the ARDSNet study I think was around 550 patients. As I recall, the other two studies were about 1,000 patients each. So these were, as ICU studies go, pretty large studies. Now, is it possible that if there would be 10,000 patients that were studied instead of 1,000 patients with 5,000 patients in each group, that the outcome would be different? Well, perhaps so, but if it requires 10,000 patients to show a significant difference, the benefit is very, very, very small, and the number of patients who we would need to treat would be very, very large. So as ICU studies go, many of these were relatively large studies. I forget off the top of my head how many patients were in the Guerin-Prone study, but it was a large study. Now, some of the other studies, like the use of esophageal manometry, for example, the current studies are small, but there are larger studies that are in process, and I think we will have more data about the utility or lack thereof of some of these other strategies in years to come, perhaps in the next couple of years, when larger studies are completed.
Thank you, Dean, very, very much. And thank you for joining us today. Thank you to our audience as well. And please join us on Thursday, July 28th for Achieving Measurable Outcomes with Pulmonary Rehabilitation with Ms. Chris Garvey. And the Respiratory Care Journalcasts return on Friday, August 19th, with the August Editor's Choice with Mr. John Gallagher. Thank you again for joining us, and have a great day.